So I'm going to go across the panel. We say we're not doing enough. We talk about the outcomes trials, the benefits, even before patients with documented ASCVD. Do you prescribe these drugs?
I do. I'm an internist and cardiologist, and I prescribe these drugs both in my role in internal medicine, but as well as in cardiovascular disease. And I think just like statins, once they became proven to reduce cardiovascular events, I think it really was paramount for cardiologists to embrace statin prescriptions and run with it.
I'm smiling because I was around when statins were first developed, and Chris, you were around too. Cardiologists were not the first. There were GI docs, there were lipid specialists, and when we started to see 4S, and then we saw West of Scotland, we say, wow, maybe they're right. Let's start using these drugs.
No, yeah, absolutely. I distinctly remember in 1993, I wanted to prescribe a statin to a patient with coronary disease, and my faculty mentor said, we are not going to do this until it's proven that it reduces cardiovascular events, and that was just around the time.
So we were kind of late to the game on statins.
Came out. Yeah. But in cardiology, we needed the evidence, but we were needed as a community to, and many times we're the captain of the ship in cardiovascular disease, to drive it forward. And the fear is with these newer antidiabetic agents, everyone's passing the ball to somebody else. Oh, I'm not responsible, or I'm not. You know, I think we have to embrace it in cardiovascular disease, and we have to teach our fellows and our cohort.
Before I go to other members of the panel on do they prescribe these drugs, and I know, Melissa, you do. You'll be last, and you'll tell us how the best use those. I know you do.
Tell us how to do it.
But
right?
before we go to the other members of the panel, you use that passing the ball. In basketball, when the clock's running down, 10, 5, that team where everybody's scared to take that shot, sometimes the time runs out and the last shot is not taken.
I know, we need Mr. Big Shot. Remember him?
Yeah.
He just grabbed the ball and he took the shot. And I think in cardiology, we need to do that. We need to be Mr. Big Shot.
All right.
So I am, although trying to learn how to do this as
it's
part
a lot,
of,
sure.
With the colleagues. So very often, a patient with diabetes has been managed, say, for 10 years by somebody, and then they see me for cardiac risk evaluation, and suddenly I say, oh, well, here, I'm going to change your whole regimen. So a lot of times, and we're actually doing a project, or Jorge Plutsky's leading it, of trying to teach cardiologists how to do this. And we're realizing that having a team and support is so helpful, so that we have an endocrinologist in the team who's given us a script of, okay, if you want to start a patient, here are the 3 things you have to tell them, because I know that I should be saying something of here are the side effects, or and what to watch out for. And then close follow-up has actually been requested by many to say we've got to make sure that someone follows up in 2 weeks. So the team has become sort of a key part, and probably appropriately should be for a patient with diabetes and cardiovascular disease. So
before I go to Seth and Melissa, because I know Melissa's an expert in this area, and I'm going to see what Seth does with these drugs, just saying we're going to refer you to the endocrinologist or the diabetic specialist won't cut it, because they're not enough.
Right, and for the patient to hear that I'm worried about their diabetes because of the cardiac risk, and we can advance the discussion certainly, and then in the right patients, then actually start it and make sure we get the information transferred to the primary care doctor, who's been managing. But making sure that we stay as a team of doctors and other educators, I think, has been important.
Okay, Seth, you're next up. Do you prescribe these drugs?
I do, and I'll tell you briefly my journey. Your comment about the endocrinologist is right on. So when I started, I would put it in my note, a recommendation, go on this drug. It wouldn't happen. So probably my notes are never read because they're so bad, but I don't know. And then I would try calling the endocrinologist or the internist, and that didn't work out. And finally, I just gave up and said, okay, I'm going to do this. Now, my start point was I haven't managed diabetes in years. I don't really want to manage diabetes, but I have to get this patient on this drug. So I began thinking about it more like colicevilam, in that that was a lipid drug with a side benefit of lowering blood sugar. Well, this I'm thinking of as a cardiovascular drug with a side benefit of lowering blood sugar. And so I'm using it not to manage diabetes, but to manage cardiovascular risk. So that's how I'm doing it now.